Welcome, everyone. We'll give it a couple minutes for everyone to load on. Good evening. Well, giving everyone just another minute to get on. We got some more still joining here. All right, I think we'll go ahead and get started. Good evening. My name is Dr. Paige Harrington. I work with Vets Pets as the Vice President of Medical Leadership, and I have the very big honor of tackling cases and working really closely with Mike Nystrom at Points East Veterinary Specialty Hospital. He joined Points East in the fall of 2020 and has been mentoring our new grads, our seasoned ER doctors, and the multiple students that come through our hospital practically every week, always learning something new, and that's always a really great time to have him around. And he's here tonight to discuss what's new about ABCs for CPR updates that are going on during the talk tonight. If you have any questions, go ahead and put them in the chat, and I will monitor that chat. We'll interrupt Mike if feel like it really pertains to the slide that we're on, or maybe wait until there's a break in the talk or even at the end for a Q&A, but I will be kind of monitoring those and figuring out when to interrupt and ask him that question. We will be sharing this PowerPoint with you guys, so don't feel like you have to frantically write any doses down or any of that information. We will send you a copy of this PowerPoint along with the copy of your CE certificate within the next week. So don't feel like you got to take a lot of notes. And then if you have any questions, again, put them in the chat. And I will go ahead and turn everything over to Mike. Thank you so much for being here this evening.
Yeah, thank you, Dr. Harrington. I was kind of cruising through the participants. I see a few people that I've seen before on here, so thank you guys for returning. Always good to see people come back, and certainly a lot of names that I don't recognize, so that's always exciting as well. I am maybe having a little bit of internet trouble. Hopefully everything comes through. If it's not coming through, whether that's voice or video, I think the video is the biggest issue. Please send a message in the chat. Dr. Harrington will pull that aside and let me know. We have a little bit of a backup plan. I can use my phone for the visual, and then we can run slides through another computer. But hopefully everything will work just fine and we won't have any issues. So my name is Mike Nystrom. I'm the criticalist at Points East. Been there coming up on now 4 years. How exciting. I can't believe it's been that long. Seems like it went by so fast. I'll give you a little bit of background on me in the next couple slides, and then we'll kind of see from there how everything goes. Actually, I don't have a background slide. So sorry about that. So I'm actually a local to the Raleigh-Durham area. Born in Durham, grew up in Cary, North Carolina. I went to school at App State. Let's go Mountaineers. And then ended up spending a little bit of time at Blue Pearl in Cary, what then was Veterinary Specialty Hospital of the Carolinas, before going to vet school at Tennessee. Had a fantastic time in Tennessee. It's hard to not bleed orange after going there. That's the orange stethoscope in this picture, still bleeding that a little bit. And then went to Tufts in Massachusetts for my rotating internship at that point. Had a great time. So beautiful, so cold, but pretty snows, especially compared to us here in the South. And then ended up going back to Tennessee for an emergency and critical care residency. Just after emergency and critical care internship, I was the guinea pig for their program. It worked out really well for me. I'm hoping it worked out well for them. And then ended up passing my boards in 2019. To become a criticalist. So I'm very happy to speak with you guys today. Like Dr. Harrington said, if you guys have any questions, pop them up there in the chat and we'll answer them as we go along. At the end, I will also have my email address on there. I always welcome communications from anyone about anything pertaining to veterinary medicine, other stuff as well outside, but with regards to this, it's a vet med. I'd like to thank Vets Pets for putting this on. They do these monthly, which is fantastic. I love giving them. They love using me for that, which is awesome. It's just a chance to kind of reach out and spread any knowledge that I might have. And then especially since the new recovery guidelines came out, back in June. We can kind of give a little bit of an update on that. To be clear, I have not read through all of them, but I have skimmed through most of them and looked at everything. So, all right, so a little bit of overview of what we'll talk about. We'll talk about what Recover is, and then kind of go through some of the aspects of Recover. So we'll talk about preparedness. So we want to make sure that we do the best that we can to be ready for these situations when we do have an animal arrest, how we're going to recognize that within the animal, talk about BLS and ALS, so basic life support and advanced life support. And then we'll move on to a little bit of monitoring and then wrap it up with what we're going to do with our animals after we get them back. That's always the moment of, oh, crap, now what do I do? That's where I'm at least at every single time it happens. So happy that it happens, but then you got to kind of go into freak out mode about how are we going to get them fully recovered from this. All right, this is the most important slide for you to remember here. And one thing, and the most important statement, is they're already dead. No matter what you do, you cannot make them more dead. So even if everything goes completely sideways during CPR, you did not make them more dead. So always remember that. And then lastly, take a deep breath. Hopefully with the knowledge that you have from in the past, a little bit of this, and a little bit of time and experience, you'll get to the point where when you're doing CPR, you're not having a huge rush and then being clouded with all your trying to remember your knowledge. So at this point, whenever I do CPR, it's actually fun for me. That's probably a terrible thing to say. But if you find a way to make it fun and exciting for yourself and learn from different aspects of it, it makes it a lot easier to be able to concentrate on the nuances of everything and how you can improve on things. All right, so a little bit about Recover. So Recover stands for the Reassessment Campaign on Veterinary Resuscitation. I'm not sure how the other vet colleges are in veterinary medicine, but criticalists love acronyms. I feel like this is a little bit of a catchy one, but how they're pulling out letters just seems kind of random to me. But I like the name either way. This was originally set up to be able to try to describe the best ways to perform CPR in patients that have undergone cardiopulmonary arrest or CPA. So I'll use CPR, I'll use cardiopulmonary resuscitation, I'll use CPA and cardiopulmonary arrest. So those are interchangeable, the CPA with arrest, CPR with resuscitation. So I might use those intermittently. This was originally developed with input from over 100 board certified veterinary specialists, and also some from the human side. I forget what ILCOR stands for, but think of it as the same thing for human side. The first guidelines were published in 2012. They had the goal to revisit that every 5 years. Well, doing the math, right now we're at 12 years and we finally got out a new set of guidelines in June. So we're not quite to where we want to be, but hopefully we can start revisiting it sooner and be in a better place ultimately. All right, so why is CPR such a big deal? Ultimately, it's so tough to know how to do this and what's the best way to do this. And that's why it's important for us to try to do everything that we can to maximize our success. In human medicine, they have so many consensus statements. They're able to do large studies. In vet med, we don't have that kind of benefit. And so the more that we can do to make ourselves successful by having some degree of some guidelines, not necessarily a consensus statement, but guidelines, the better success we can have. But as of right now, probably less than 6% of animals survive to discharge when they've undergone cardiopulmonary arrest and we've attempted cardiopulmonary resuscitation. So that animal dies, we start to do CPR. Only 6% of the animals will survive to discharge. Honestly, the number for survival of CPR or return of spontaneous circulation that we're targeting is probably close to, in my experience, probably close to about 20-25% or so. But again, some of those animals we might end up losing later on and they might arrest again. Some of them might end up being euthanized because ultimately it's probably going to carry a poor prognosis, and many of them, at least in my setting, is critical care. Other ones that are related to anesthesia, let's say a 2-year-old lab that came in for a teeth cleaning, a dental, that's probably going to have a good prognosis, and hopefully that one can recover pretty well. But very sick animals are going to be even less chances of survival. Anesthetic related arrests, so these are things related to medications, the volatile anesthetic gas, or something that we've done, like we forgot to turn their oxygen on. So arrests related to those are going to be much higher. And a big portion of that is one, we're probably already going to have an IV catheter in place. Two, hopefully we've got them intubated already. And three, we're probably already monitoring it. So we might be catching these guys a lot sooner. And we've already got some of the steps of basic life support already initiated. That makes it a lot easier for us going forward. And one step of advanced life support, which is having IV access. In human rates, they usually report success or return of spontaneous circulation and discharge of the hospital up to about 40%. When you look at 6% compared to 40%, to me, that's huge difference, which just tells us that we've done a terrible job. And that's the reason for the recover guidelines originally posted. I haven't seen any marked differences in numbers or publications since the original guidelines. I'm hoping that we'll come out with something based off of the database that people have been collecting since that time period. But we'll see if those are going to be posted anytime soon. All right, so I do have polls throughout here. This is going to be our first poll question. So have you ever had success performing CPR on animals and having them survive to discharge? All right, let's see. All right, so about 35% of you have had success. Can only count it on a single hand, but that's fantastic. And then about a little over half of you are still trying, so that's great. That's all that we can really do at this point. I will say that I've probably had success in, I probably 20, 30 successes over the years, and that's doing critical care for now, let's see, 2014. So now about 10 years. So that's living in this environment and knowing what I know. So even having a handful of them is fantastic. So congratulations on that. Keep working for those that haven't had success. It's not, it's still worth trying and still worth going for if we can try to save a life. All right. So what is our goal of CPR? I've actually already mentioned this once. And so hopefully this won't be anything that's new for many of you, but our goal is return of spontaneous circulation. And what this means is that we've gotten the heart to start beating again and start to move blood. So spontaneous circulation really just means that the heart's beating on its own and we're not having to control it and we've got blood flow moving. So ROSC, it's kind of a little bit tough to say. It's also tough to say the expanded name. So I might use those interchangeably as well, along with the CPA, CPR. Hopefully it doesn't get too confusing for everyone. All right, so talking about the guidelines. This is for the original guidelines, so OG guidelines. There are 7 components to it. The first one talks about the evidence review and the consensus process, all the boring stuff that no one really ever wants to read, but those people that are really into it, certainly by all means, be my guest. Second part talks about preparedness and prevention. So what are we going to do to maximize our success and also minimize our likelihood that we're going to have an animal that will arrest? Next up is basic life support, so BLS, and ALS, and these are different articles in each one. So the original guidelines had 7 different articles, all published within VEX Journal as a special publication. So that's what I mean by the 7 different components. Next up is monitoring, post-cardiac arrest, and then my computer is actually showing me what this one is, the clinical guidelines. So ultimately, what I will tell you is that the clinical guidelines is what you really want to look at if you look at one thing. The original guidelines are the ones that assess the most aspects of care. The new guidelines build on top of that, but they don't go over the clinical guidelines again. So always read part 7 of the original guidelines and then read the new stuff would be my recommendation. You do not have to go through all this advanced life support, basic life support monitoring, post-cardiac arrest. So ultimately 1 through 6 again, it's not going to provide you with a lot of information. The clinical guidelines, if you choose one segment, is the only thing that you really need to listen to or read, really. All right, so the new guidelines. So what do we have there? Again, these just came out in June, so they haven't been out very long. We've got 5 different articles for this. So we went from 7 to 5. First one, again, talks about the evidence stuff. Second one, basic life support. So we've eliminated the preparedness and prevention. Advanced life support, monitoring, clinical guidelines. So kind of more or less similar in regards to everything we've cut out, but it does help. For each of these, interestingly, I found that these read a little bit different than original guidelines, and that you can actually get information in basic life support and advanced and monitoring that necessarily or does not necessarily present in the clinical guidelines. So if you really want to know some of it, go through those. Otherwise, you can just read. They use a PICO type presentation. Don't ask me what it stands for. I always forget it. But it presents the information at the end of each topical question, kind of in a succinct order. So you can go through those and just find the answers to those, or what questions they were looking at would be my recommendation. All right, so preparedness. Oh man, this malaligned here, but I always say the 5 Ps. I actually add a 6th P to this, but I say proper preparation is going to prevent poor performance. The piss is the last one. I probably shouldn't say it for this presentation, but that's the person who I am. So I do 6 Ps. I talk with my kids about this all the time. If we're prepared, then we're going to have better success, really, for doing whatever we need to do. And we'll talk about ways that we can be more prepared as well. All right, so the keys to that. 1, organized and pre-stocked arrest stations. So at my hospital at Point East in Wilson, I have the benefit that I have an arrest station where we do CPR, and we will bring animals to that station. We also have a mobile arrest cart, or a CPR cart, that we can bring over that has everything we need in it. And I'll show you some pictures of a cart. Not everyone's going to have that benefit. So one thing that you can do is create a crash station where you have an anesthetic machine in a general practice setting, and hopefully you have a little toolbox that you can keep all your drugs and everything that you'll need in there for that. But hopefully at your anesthetic machine, you'll have endotracheal tubes, you'll have tie gauze for tying in the endotracheal tubes, you'll have everything else that you need there, so you don't necessarily have to have a full-on crash cart like what we have. Again, often located where an animal is being anesthetized. It's just the simplest way of doing it. Other things that are important, doing debriefing after CPR. And this is one thing that I really like to do. I like to challenge the team that I work with to say, hey, what do you guys feel like we did better? What do you feel like we didn't do, or we did really well? And that way they're also participating, and it buys a whole lot of, or gives them a whole lot of buy-in to, I'm actually part of this. I'm going to be successful next time because now I can look at this aspect of everything. Training programs are always beneficial. We have a very loose training program at Point East. We do have a CPR dummy now, and we are working on doing training for our staff, but we have not done a whole lot, honestly. A lot less than what I should be doing. Leadership and communication is a big thing. Many people think that a doctor has to be the one running a CPR code. That is not the case. Where I worked or did my residency at Tennessee, there was one technician that would almost always run the codes whenever we had them happen. And I was always happy to step down and let her run the code. She did a fantastic job, and I'd help out with some other aspect of it. And then practice dummies are useful. You don't have to have a $2,000 practice dummy. But even just having a large stuffed animal that looks like a dog that you can practice on and kind of make it somewhat real will help tremendously as a demonstration. All right, so a little bit about the crash cart box. So what things are we going to want to have in it or around us for a crash station? So we're going to want to have endotracheal tubes. What I usually recommend is one of every size, and I just go for the even number, or sorry, not the even numbers, the whole number. So size 3, 4, 5, 6, 7, 8, all the way up to size 12 or 51 French, whatever it is, type of tubes that you're carrying. Just that we have one of every size available. You don't have to have 6.5 and 5.5. Probably not necessary, and everyone's freaking out while they're doing CPR and trying to get them intubated, so it won't make a big difference if it's perfectly positioned or perfectly fit to the endo or for the trachea itself. Laryngoscope's always going to be helpful. Looking back into these guys' throats is very challenging, especially because many of them are already going to be in lateral recumbency. Hopefully someone's starting to do chest compressions on them, and so you've got a moving patient trying to intubate them in between their retinoids. And inevitably, without a laryngoscope, I can almost guarantee I cannot intubate an animal that's sternal without a laryngoscope most of the time. But in lateral, I can almost guarantee I'd intubate the esophagus. So I would always recommend a laryngoscope. For breathing for them, you're going to want an ambu bag if you have it. Not a big deal if you don't. We rarely ever use the ambu bags that we have at Points East. We have an anesthesia machine sitting right next to our crash station. And so many of the technicians are more comfortable with the anesthesia machine. And so they just grab that and it's already hooked up to oxygen and ready to go for them. And they can start bagging that way. Don't forget to tie in your tube. Definitely very important. You don't want that tube popping out after you just made up all that effort into getting it put in place. Monitoring equipment, so we'll talk a little bit about that at the end and what's useful and what's not. And then drugs, of course. That's going to be part of our advanced life support aspect of treatment. For us, at our hospital, I already said we have a permanent crash station. We also have a mobile aspect of it. And then in our operating rooms, we have little toolboxes that have little crash kits in them. So that's always important to have some aspect of mobility in case an animal's arresting in the OR, but your anesthesia machine that you usually knock down patients at is, in the radiology suite. So you just want to have some degree of mobility to be able to take things that you need to wherever your animal has arrested. And then lastly, something to monitor on. Now, Recover does have CPR monitoring sheets. They are excessive. At a minimum, they are excessive. They're really meant for database logging of cases and try to assess improvements for where we can improve during CPR. So they're a little bit too much, I would say, honestly. But you can access them online on the Recover website, and I do provide that at the end, the access to the website. And it is free of charge to everyone, by the way. All right, so this is a crash cart that I've had at my previous hospital. So this is a more or less a mobile toolbox, but it's a medical grade one. A few things here. We do have ties right here on the drawers. This crash cart was treated as a holy site where you don't go to get endotracheal tubes or drugs that you need or syringes. This was meant for only doing CPR, and that was it. This is a metronome. There are much, much smaller ones that you can use for doing CPR. We'll talk about that a little bit later on. This right here is a defibrillator. We do not have a defibrillator and have never had a defibrillator at Points East Hospital. If you do not have one, it is not the end of the world. It probably contributes to maybe a 0.25% increase in success at CPR in my experience. So not having it's perfectly fine. This hospital, we did have suction, which is some of these suction canisters, and we had suction on the wall, and then some other material here. This is the ECG for hooking up to the defibrillator. That way you can have a closed circuit with that. And then lastly, one thing that's important because all of our countertops are way too tall is there's a stool right here attached to the side of the CPR cart, such that you rip it off, you set it up, and you can get above patients. This gurney is a rising gurney, so you can actually adjust the height of it if you needed to during CPR. We only have those at Points East, but most places don't. They have a rigid gurney. And so the step stool can certainly be helpful for that. And I would recommend having it with your crash cart if at all possible. I guess lastly, there's a tourniquet right here in case you're having trouble trying to get an IV catheter into them. All right, so this is top drawer for that crash cart. We've got various size endotracheal tubes. For this hospital, we had half sizes. So here's an 8.5, here's 9.5. Did have a suction bulb for suctioning out the airway in case there's a bunch of secretions back there. And also over here on the left, there's a blue stylet, which is helpful, especially in cats. Intubating cats is notoriously difficult. Add in doing CPR at the same time, and it's even worse. On the right side is a basket that has a laryngoscope with a laryngoscope blade in it. It also has some tie gauze. And then top right, that Emma is a mobile capnograph. Extremely useful. The batteries die very rapidly in it, but useful to have. I will say that the one thing that's not useful probably on here is a mouth gag, but this is what was kept in the cart. I didn't feel like it was necessary to change it. Second drawer for this hospital had IV fluid lines and IV fluid bags. So we've got saline, we've got LRS, there's vet starch in here as well. Any of these are reasonable. I don't feel like it's necessary to keep in a crash cart, but have close by is certainly a good idea. Next drawer was our drugs and syringes, really. So we've got epinephrine, atropine as our main ones that we'll talk about. There's some reversal agents over on the left. Let's see, naloxone, I can at least see. There's some norepinephrine, which I would not consider a crash drug. Bicarb is not generally considered something that we're going to use during CPR, but we will touch base on it a little bit. Flush syringes, some labels, and then various other syringes and IV catheters. There's also over here in this blue basket, there's supplies to be able to do a cut down on a vessel. Clearly that hemostat is not sterile. In the grand scheme of things, we're not going to make them more dead. So we can always start antibiotics after we successfully resuscitate them. But getting venous access is going to be an important aspect of the advanced life support. One other thing I'd like to point out on this picture, if you see at the very bottom, these drawers also had labels on the drawers. So that's very important. So that way, someone that's not familiar with it, I think has 7 drawers, so quite a bit. And so we've got labels on each one of them. So that way we know where to find everything. Next drawer down, so this is the bottom drawer at this hospital. They've got ambu bags. They've got a tap kit for tapping chest or tapping pericardiums. They've also got some useless stuff like this trocar style chest tube. I'm not sure why it ended up in there. I think it was just because we had no other place to put it, so why not put it in the crash cart? And then some sterile gloves, along with some supplies in here for doing open chest CPR. I believe we also had a paddle set for doing internal defibrillation if we had the chest open, so we could defibrillate directly on top of the heart. That's pretty wicked to see. And then some other supplies over there to the left. All right, so that's it for the crash cart. Your crash cart does not have to look like that. Ours at Points East does not look like that. And so that's perfectly fine. Find out what works best for you. Ideally, drugs, syringes, flushes, and those being the big things. And then some place that you can get the endotracheal tubes, the intubation tools, an anesthesia machine, and that be your crash cart. All right, so a little bit about training programs. So how are we going to work to try to become a better team for this? Ultimately, practice makes perfect, right? Or hopefully as close as we can get, because no one's going to be perfect, and our numbers are, even with the best team, our numbers are still pretty abysmal. But in a team setting, and so if you're out in your hospital and let's say you've got one veterinarian, one technician or support team member, an assistant, and a receptionist, you can do CPR with those. All it really takes to do CPR is 2 people, honestly. It's a lot easier when you have more, especially at the beginnings. That way you can have a team or a couple people working on getting an IV catheter, 2 people working on getting intubated, someone doing CPR, someone grabbing stuff to breathe for the patient. But it really only takes 2 people to do CPR. But when we do these training programs, include everybody, including the receptionist. That way everyone can be involved. It's going to maximize our potential to be successful. And there's no reason for a receptionist to be answering phone calls if we've got a patient that's dying in the back. It'd be much better use for them to be in the back, even if they're just recording stuff. That helps. All right. And then lastly, familiarity with different aspects of CPR is important. And that's why getting the whole team in there is helpful. But training, everyone should be trained on every single role is a best idea for us to do. I might be very terrible at giving animal breaths appropriately because I get distracted by everything. So there might be other team members that are better at it. Whereas I might be good at doing chest compressions, especially if we have a bigger dog. Most of us work with a predominantly female population of team members. And so a large dog, it's going to be helpful to have some larger or heavier or stronger team members, and I can potentially fit that role at times. Now, I might not be the best or the most supportive for like doing cat CPR. There might be other people that are more gentle and appropriate and not crushing an animal's chest, but each team member can develop where they're at best and how we can kind of get the best flow. A little bit about leadership. They talk about closed loop communication. So what that means is if I'm working a CPR code with John and Fiona, and John's pulling up medications, I say, John, pull me up 0.3 milliliters of epinephrine. And John goes, all right, pulling up 0.3 milliliters of epinephrine. And then he hands it to me. He goes, here's 0.3 milliliters of epinephrine. And I say, all right, thank you, John, 0.3 milliliters of epinephrine. And I say, Fiona, please give 0.3 milliliters of epinephrine followed by 10 milliliters of flush. And she says, all right, I'm giving 0.3 mils of epinephrine followed by 10 mils of flush. So that closed loop communication, especially in stressful situations, allows us to make sure that as a team, everyone's in a cohesive unit. So me and John are communicating. He's telling me that he heard me tell him what to pull up, and he's pulling up that drug. And then I'm telling Fiona to give it, and she's saying, all right, I'm giving it for you based on what you told me to do. And so that's really important in these stressful situations. I cannot emphasize that enough. If you have enough people, having someone that can evaluate our basic life support and having someone that can evaluate our advanced life support is important. So we'll talk about different aspects of what classifies basic life support and what classifies advanced life support. But many times we're stuck, not stuck, but many times we're in a situation where whoever's leading everything is doing both of these at the same time, and that's perfectly fine. They might also be working on doing compressions at the same time. The more practice you get with it, the easier all of it becomes to do at once. But does take practice for sure. All right, practice dummies. So this is Jerry. I can't remember what Jerry stands for. Some people call him critical care Jerry. There's a CPR Jerry, a number of different aspects. This is actually the dummy that we have. We have a newer version of him at our hospital, well, in our hospital system with Vets Pets. So he has a number of different things that we can do. We can do mouth to snout. We can intubate him. He does have these tubes running through him, so we can try to place catheters in him as well. And he has a fake lung system such that you'll actually be able to see his chest go up and down, which is kind of cool. This is Casper. I've not seen him before, but he's a rubber dog. Kind of freaks me out, honestly, to think about doing this, especially since his head's all cocked sideways like that. But they, again, acronyms, Casper, they took CPR and added some letters to it, really is what they did. But either way, even just a normal stuffed animal about the size of Jerry here would probably be perfectly fine. You don't have to have the perfect thing. All right, and then this is my favorite part, working with a team, is the debriefing. It's just fun to get them involved with every aspect of what we're doing. So regrouping after a CPR event is very key to me. I already mentioned, what did we do well? What can we do better? How do we communicate? Again, that's a big portion of doing CPR. I teach my team closed loop communication as much as possible for these events. And then did everyone know their role? These are common questions that we can ask, but sometimes if we just throw out a question, what do you guys think we did well? It is fantastic to get input from everybody. And some people might think that they were doing something really well and they were doing it terrible. Or they might think that they were doing it terrible, and then you can give them the feedback and say, no, you actually did this fantastic. And that's even better, because then you're going to lift them up and carry them through this. The last thing that's very important, and we carry this a lot as a veterinarian, is to not forget that our nursing team members often bleed for our patients. And this is one thing I learned during my residency, especially with younger students, but nursing staff too, is they're the ones on the ground doing all the grunt work with patients, getting to know the owners a lot more than what we often do, and loving on the patients. And so one thing that's very important during this debriefing is to check on people and see how they're doing. Hey, I know this was very rough on you. This was rough on me too. If you need a couple minutes, why don't you take it? But just know that we're here for you too. Or hey, do you need to take a break? Or you just want to power through this and get to the next thing so that way you can get to the end of your day. It's always important to take into consideration. But definitely debriefing, big key to improving. All right, so how are we going to recognize CPA event, cardiopulmonary arrest event? This is an algorithm for the new recovery guidelines. This is 2024 algorithm. I love it because it makes me laugh a little bit every time I look at it. So if you see an animal that's unresponsive, that's the first key. We got something going on. Call for help. I love how it has it looks like a calculator, honestly, not necessarily a phone. But call for help. Hey, I'm worried about this patient, or hey, I might have a code. And then shake and shout at the patient. That's one part that I really love. We don't often do that, but that's something that they talk about on the human side. So I think it's pulled from that. So if you get no response from that patient, then you got to check and see whether or not they're breathing, right? And if they are not breathing, go ahead and start working on your CPR aspect of everything. If at any point in time they respond to you, then clearly they don't need CPR. So if they pop up and they're just like, oh gosh, dude, I was just in a deep sleep, leave me alone. Then don't start CPR, and that makes perfect sense. I have started doing CPR on patients that when we go to intubate them, they end up biting the tube or biting my hand. Did I do something wrong? Well, maybe so, but it's always better to start CPR and not lose out on that time than to miss out on 15 to 30 seconds of doing compressions, trying to figure out if that animal's arrested. They do talk about down here, depending on the number of rescuers that you have, if you've only got one rescuer here to the left, make sure the airway's clear and then start basic life support. If you've got more than one, then you can start basic life support while the other person is getting the airway secured. All right, so a little bit more about how to recognize cardiopulmonary arrest. Ultimately, there's 3 criteria: an unconscious or unresponsive animal. That takes care of that top little thing that was in the last algorithm. Apnea or agonal breathing. So we all know what agonal breathing looks like. It's terrible. That's typically an arresting animal, not an alive animal, or not breathing at all. This certainly makes sense. And the last one that people put in there is absent pulse or heartbeat. What the big stress is currently is to not pursue evaluating a pulse or heartbeat if you've met 2 of these criteria. So as an example, here's an unconscious man after a fight, and then sculpting. Clearly this Yorkie is alive. It's standing up, but palpating for a pulse or listening for a heartbeat. Those 2 are not always, or that last one, sorry, is not always necessary. So ideally what we say is you need 2 of these to start CPR, would be best. And you should have your primary or your survey for these aspects. It should take you hopefully less than 15 to 20 seconds. Because then you need to get the animal out and start working on therapy or treatment with basic life support and advanced life support. All right, so BLS. So the ABCs is how I remember learning about this whenever I was in college, I think. Or even before maybe. I never took a CPR course, so I don't really know. I'll give you, in each one of these next sections, I'll talk about the major updates for tonight. Some of these aspects will not be important for you at all, and you can just kind of throw them in the back seat, which is perfectly fine. I'll try to highlight the ones that are important. So starting up, the new highlights that they emphasize, so when they're on their side, you want to ideally compress their chest about a third to half the width. If you feel like you're about to break ribs, you're doing it right. If you have broken ribs, you're probably doing it a little bit too hard. With that being said, a lot of old dogs and little dogs, I often break their ribs when doing CPR, and it's elasticity that a younger dog does. For dogs in dorsal recumbency, so on their back, these are going to be our bulldogs, our square-chested breeds. Ideally, you want to target about a quarter of the thoracic depth. So from their sternum to their spine, about a quarter of that depth is what you're going to target. It's really weird to do CPR on an animal's back. It just feels uncomfortable, unnatural. I often don't do it. Ideally, only interrupt chest compressions if there's evidence, and strong evidence is what they say, objective as well, of ROSC. So you've got something that's pointing to the fact that you likely have an animal that has a beating heart again. Also include, and we'll talk about it later on, are other aspects, changing out compressors or evaluating ECG for arrhythmias that may be arrested arrhythmias that need to be treated differently. This is one that's probably not very important. Peak inspiratory pressure required to see, or they recommend using a peak inspiratory pressure required to see a visible chest rise. I don't know if I'm paying attention to the chest at all and watching it rise whenever I'm doing CPR. Ultimately, if I'm monitoring or have my monitor hooked up and I'm getting CO2 readings, if I'm not getting any CO2, I'm going to check and see whether or not I'm in the airway or not. It's kind of what I go off of. And then this is kind of new this year. If you cannot intubate an animal, so this is because you don't have endotracheal tubes or endoscope, then you can use a tight-fitting mask with a black bellows, and I'll show you a picture of this, that goes over their both their nose and hopefully over their lips, and then give positive pressure breaths that way. The one thing you have to do, you have to make sure whenever you give a breath, you hold that onto their face, because once you give a breath, it'll pop right off. Had that happen a few different times. It's no longer recommended to do mouth to snout or mouth to nose ventilation. If you don't have a face mask, then absolutely do the mouth to snout. But if you do, then do the face mask would be preferred. All right, so which way do we do it? Do we do it airway, breathing, circulation, or / compressions? Or do we do it, start with compressions and then get the airway and breathing going? Ultimately, to me, it doesn't make a difference. I will say that we often have at Points East enough team members such that we throw a pet up on the table, someone starts doing compressions, and then the other teams work on getting an IV catheter or getting an airway claimed, so getting them intubated. So really depends on you and what you want to do and how many team members you have available. For single person CPR, they recommend doing compressions first and then breathing is the recommendation. So maybe CAB is actually the more appropriate way of doing it. All right, so other recommendations. We talked about assessing a patient for CPA. So work on doing that rapidly and then immediately initiating compressions, getting them intubated and breathing for them is a big key for that. 2-minute cycles, and I'll go over in just a minute on the next slide why this is important. So it's helpful to have a clock nearby. Hopefully you're not using one clock on the wall and the person recording is using their watch or their phone, and then someone else is going off of a different clock. We all, as a team, need to be on the same clock. So usually a clock above the wall, right where we're doing CPR is probably the best thing, or we establish whose timer we're going off of. All right, so this is a chart pulled off of the Recover Basic Life Support not guidelines, course online. What this shows you across the x-axis is ultimate time of doing compression, starting at 0, going to 240 seconds, so up to 2 minutes. Sorry, up to 4 minutes. And then on the left talks about arterial blood pressure. So in this green line, if you follow it, is how well we're moving blood. So our target is to be at that dotted line at the top, so this maximum blood flow here. And when we're doing compressions, it takes a new compressor about a minute to get up to maximum blood flow on what they can create doing compressions. So doing CPR for less than 2 minutes limits how much time we're at this maximal blood flow. If you cannot do it because you physically get exhausted and you're running out of steam and the pet's not getting good compressions, then that's the same as you that's probably worth you stepping down and getting someone else in there. So if you can't go for 2 minutes, there's no big loss. We ideally want to do it, but sometimes it can't happen. So try to target 2 minutes as best as possible, as long as you feel like you're doing good compressions. If they start to fail or they start to become more poor, then get someone else up there. I did not understand this until I took the Recover course 3 years ago. And I thought it didn't really make a difference. So this was something that I learned. Great course to take. I do recommend it for anyone, including myself as a critic was. So I really enjoyed learning a whole lot from it. All right, patent airway. So what are we going to do with this? We're going to have an endotracheal cuff or endotracheal tube and make sure that it has a cuff on it. So uncuffed tubes will not be beneficial because when we give a positive breath, that breath will just come out outside the tube, path of least resistance. So it has to have a cuff on it to get a tight fit in that trachea. A laryngoscope, as we talked about, is going to be very important. Secure that endotracheal tube. I've had them fall out before. It's extremely disappointing, especially in a difficult intubation when that happens. So always try to get them secured in place. And then you may need temporarily stop compressions to be able to intubate. This is not uncommon for it to happen. It's hard to intubate laterally, but when they're moving in lateral, it's even harder. Sometimes you got to stop compressions, get them sat up sternal, and try to do some compression side to side while they're getting them intubated in a sternal position. It's better than nothing, but just try to get them intubated. Have suction ready for secretions or hemorrhage in the back of the throat. Emetic contents are not uncommon to find, which is very gross. And then also gauze to hold the tongue. Many of these dogs at arrest will have lots of salivation going on too. So that gauze is going to be really important for holding the tongue. And you can also use it to swab the back of the throat. All right, so breathing, I'm going to speed up just a little bit here. I'm long-winded, so I apologize. I want to make sure I get through all this in a reasonable time. So we're going to give about 10 breaths per minute. So once every 6 seconds. I have 6 to 10 seconds in here. It'll be okay if you do every 10 seconds. That's perfectly fine. or every 6 seconds, whatever you choose. I think the new guidance actually recommends 6 breaths a minute. So that way you're doing it every 10 seconds. It doesn't really make that big of a difference. 6 to 10 is perfectly fine. Tidal volume, I don't know how people actually measure this or you get an idea, but they're target 10 mils per case. So if you have them on a ventilator, that's easy to do. Most people don't have them on a ventilator, so it's not a big deal. And then the inspiratory time, so the time that you're squeezing that bag, you want to make it 1 second. So don't squeeze and hold it like you're recruiting alveoli. You want to squeeze and then let go and then leave it be. Here's an ambu bag. So you would squeeze the ambu bag and then let off completely. So that way it can refill on its own. All right, question time. And if you have any questions for me, feel free to throw them up there in the chat. But you guys get to answer my question. What can you do if you're unable to intubate a patient? All right, let's see what you guys got. All right, so most of you said bag mask ventilation. That's fantastic. When I did this talk, I can't remember if I did it last year or the year before, I would have said that I think mouth to snout is the most appropriate thing. So you guys are paying attention. That's fantastic. Mouth to snout is certainly an option if you do not have a bag mask. Holding up oxygen to their nose. Remember that doing that won't get them to actually take a breath in, so it won't be hugely beneficial because they won't be breathing on their own. And then a nasopharyngeal oxygen line, similarly, they're not going to be moving air on their own, so you have to find a way to be able to expand their chest cavity. And the only way we're going to do that is with positive pressure ventilation. So, all right. Let's see, I always got to click back to the screen after this. All right, so if you can't intubate, bag mask ventilation. So ideally a mask with tight-fitting bellows. I actually don't think I have a picture anymore in here. I thought I did. And then otherwise you can do mouth to snout or mouth to nose is what they call it. If you are doing either one, make sure that you get the mask or your hands over top of the commissures. Remember, they come back pretty far in dogs, not so far in cats. But if you just have it over the tip, they might blow out air through their commissures of their lips. So one important aspect of this. So in this picture, this person has their hands coming up, covering most of their lips over here and hopefully the palm of their hand there. And right over top of their nose. I thought I had a picture of one other, but I don't. So I've never had to do this, thankfully. I have done the bag mask ventilation because we do have bellows right next to our crash, or as part of our crash table or cart area. So I prefer to do that if I can. All right, so compressions. This is probably the part that most people kind of freak out about. We're going to do compressions at about 100 to 120 compressions per minute. So there are songs that you can sing for this. Everyone has a little bit of a different song that they'll sing, but no faster than 120. What most people will do is they're so pent up on adrenaline of their own that they're doing compressions much faster than that 120. What that's going to lead to is exhaustion on your part and decreased blood flow return back to the heart because you're not giving it enough time to fill. So think of it as a diastolic issue of filling blood back to the heart. So you're going to compress, we already talked about this, about a third to half the chest width at the site of compression, whether you're doing it over the heart or over the widest portion of the chest, and we'll talk about those. So you don't want to be doing compressions and staying on the chest the whole time, because what you'll end up doing is keeping that chest from being able to recoil. So you want to come off the chest such that that chest can then inflate again. That will help with increasing airflow into the lungs. It will also help with increasing blood flow back to the chest cavity and to the heart. As that chest recoils, it pulls blood from the periphery back to itself. All right, and this is where it gets to be sad, but understanding that at the best compressions, we're probably only creating about 20 to 25% of normal cardiac output. So that's pretty poor. And that's why some of our monitoring we're going to eliminate as or put in the ineffective area that we'll come to later on. All right, so quick question. What song do you guys sing when you're doing CPR? All right. Whoops, sorry. All right, let's see. Staying alive. We got some optimistic people out there. Fantastic. All right, that took most of the bait. 5% took other, and then about 10% took another one bites the dust. I like the NSYNC reference. That's fantastic. And then Thriller. That's really good. Um, I sing Another One Bites the Dust. I can just get the beat better in my head. And honestly, it just seems more realistic, which is terrible. I know because my goal is to get them alive, but I can just get the beat a lot better in that. So it's always fun to know what people sing. These are all songs that get you close. Again, we'll provide you this presentation so you don't have to write these down. I always love that. I don't know if anyone remembers Mbop by Hanson. Never would have thought that that was one, but certainly funny to see on there. And then there was one other one that gives me a laugh every time I see it. Oh, Dancing Queen. So great songs. Well, Dancing Queen's a great song. Mbop is a little bit questionable there, but fun to see these different beats on these. All right, so what are we going to do about compression pauses? I kind of already hinted at this earlier. The goal is to only stop for short periods, so we try to keep that less than 10 seconds at a time is the goal. I do have 10 to 15 seconds. Sometimes it's not capable of doing less than 10 seconds, but that should be our target. We're going to be looking for what arrest rhythm we have. So hopefully we have an ECG hooked up to them as part of our one compressor stepping down, another one stepping up. And I say stepping down and up, remember, because we're going to be hopefully using that steps tool. That's also an important place to use good communication. Person compressing goes, all right, I'm going to step down to the left. Why don't you come over here to my right and you can step up as I step down. And that way, it'll hopefully limit any time where you're not doing compressions. And then if you're a sole person doing CPR, we're going to stop to do a couple breaths. So the recommendation for that is to do 30 compressions and then give them 2 breaths. So that's roughly about a breath. If you're doing, let's see, 110 compressions a minute, that's roughly a breath every, 15 seconds or so. So it's not a perfect numbers for either one of them, but that's the current recommendations. And that's completely pulled from human side of everything. All right, so 2 different compression techniques that we'll talk about, cardiac compressions and thoracic. So cardiac compression method, we're going to be compressing directly over top of the heart. So we're going to be using these in small patients. So cats are the perfect example, and dogs less than 15 kilograms or about 30 pounds. You can also use it in dogs with keel chest. So the sighthounds are a perfect example of this. We can have a borzoi or a greyhound that's larger than 15 kilograms, but we might be able to get good compression over their actual ventricle itself. Again, hopefully directly over the heart, and hopefully in particular the left ventricle. We don't need to be compressing over the atrium because that's not going to help move blood out of the heart and to the important tissues, the brain and the heart itself. So this is a very, 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 very ugly cat. I think it's a cat at least. 2 different methods that you can do these compressions, but we're going to go directly over top of the heart. This method, honestly, with your thumb and your finger certainly gets exhausting. My thumb starts to cramp. I can't do it very well, so I do a little bit of a modification of B here. This is an example of looks kind of like a sighthound, but not very big sighthound, also not a very attractive patient, doing compressions on a keel-chested dog directly over top of the heart. They do recommend interlacing your fingers to some degree. I don't always do that, but it does sometimes help me, especially in dogs that have a lot of skin that's rolling all over the place to interlace them. And it also helps to get 1 unit of compression with your arms. The thoracic compression method. So this is going to be over the widest portion of the chest. So it's often caudal to the heart and dorsal to the heart. It makes you feel really uncomfortable and like there's no way that you're actually doing compressions well enough for this. And it's usually going to be around ribs 8 to 10. So if that gives you an idea. Remember, the heart sits probably around ribs 4 to 5. At least the ventricle does. So quite a bit further away. What we're using in this is changes inside the chest cavity of pressure to then compress the heart. So we're not compressing the heart itself, we're compressing the chest that then compresses the heart is the hope. It is clearly less efficient than the cardiac method. Again, this is a maybe better drawn dog. But if we envision his diaphragm and his rib cage coming to about here or so, we're pretty far caudal back here. TikToker's here, so we're caudal, and we're also going to be dorsal. And this is where we can really start to roll off the either side of the patient on these larger patients. So lastly, these inbred, I call them mutants. Although we love how they look and sometimes how they sound, most of them have great personalities, but these barrel-chested dogs. So these are the English and French bulldogs, the Boston Terriers as examples. You could probably throw in bull terriers potentially into this category as well. There's a few others, but the dogs that have a square chest, more or less the same from the side as they are from the top. Oftentimes doing these in dorsal recumbency is reasonable. It makes me feel uncomfortable. If they don't balance well on their back, then you probably should have seen to go to lateral. If they balance well on their back, then you can continue to do it. But clearly, this is not going to be a very efficient way of doing CPR. All right, other thoughts. There's something called interposed abdominal compressions. This is a gross picture because it's of a human. Humans are gross. But whenever your compressor is compressing over top of the heart, your person on the abdomen is off the abdomen and they're alternating. So it's kind of like this kind of method. So the goal of this is whenever you're off the heart, let's say heart is right as my hand here, you're compressing the abdomen and that's getting blood flow from the abdomen back up to the heart. And then you come off as they compress down on the heart to allow blood flow to go other places. So this is not really something that's typically recommended. Some people will put a belly wrap or a belly wrap with a towel around an animal's abdomen to help decrease blood just accumulating in the abdomen. We're not going to do this in patients that have our post-op abdomen. So a post-op, let's say SPAY or an enterotomy, we're not going to do them on those. Hemoabdomen and then any other abdominal disease. I've not really done this. I've tried it a couple times. It's very hard. Mostly I do it to show people, and then we all get laughing about how terrible I am at it. All right, on to advanced life support. Let's see, still no questions. No questions at all. Please feel free to ask questions as we go along. And I'll try to answer them. All right, so advanced life support is going to include things like getting IV access, our drugs that we're going to give, monitoring any electrolytes and correcting those. Included within electrolytes is talking about glucose as well. Replacing any volume deficits that we might have. So by volume, we mean IV fluid deficits or hypovolemia. Correcting an anemia. So some patients might have low red blood cells as their cause of arrest. So we might need to do something about that. Interestingly, there was a case report a few years back of someone giving, during CPR on a cat, they gave intracardiac epinephrine and intracardiac dog red blood cells to a cat, and it lived. Like, it's unbelievable. Like, what? I mean, I can't believe it. I would never think about that. I admire the person just reading the story of it, and that cat lived. It survived 3 weeks later. So really incredible. Defibrillation is going to fit into this category as well. And then lastly, open chest CPR. So ultimately, everything except for basic life support. So airway, breathing, compressions. Those are basic life support. Everything outside of that falls into advanced life support. So our monitoring, our ECG, our capnograph, any monitoring that we're doing is also going to fall into basic life or advanced life support. Do not do advanced life support until you've done the first 3. All right, these 3 are what saves the animal. This is supplementary for the advanced life support. So that's an important concept to remember. All right, so major updates for this go around of the recovery guidelines. They are going to prefer giving IV dosing over intraosseous dosing. So if you do not have access or you cannot get access to IV, then giving intraosseous is perfectly fine, but don't prioritize IO, intraosseous, over IV if you can get IV access. So one important aspect. Thought that was probably not worth really stating. It's always going to be something where I'm going to prefer IV over IO, but some people might take it otherwise. There is no longer a high dose of epinephrine. So the last guidelines recommended against doing it, but you could potentially do it for your last dose. Now they're recommending not doing it at all for high dose. And I'll talk about that when I talk about the drugs and indicate why that is. Atropine, they're recommending just giving once because of its long duration of action. Makes perfect sense. I used to give it every 3 to 5 minutes because that was the prior recommendation. And now they're recommending just once and given it as early in CPR as possible for treating atropine-related diseases or responsive diseases. For those that work in a hospital that has everything available to them, and they just want to do everything possible. Guess what? This is not always me for what I can do or what I can't do. But for animals that have shockable rhythms, so we'll go over the rhythms, but that do not convert after defibrillation or a thump, you give them another 2 minutes of CPR, and then you can try other drugs like vasopressin, esmolol, or lidocaine in dogs and amiodarone in cats. We do not have vasopressin at our hospital. We do not have amiodarone at our hospital. Excuse me. So those are not going to be things that we're going to be doing. We do have esmolol, but I have never grabbed it for CPR. So that's why I put for the hardcore. These are supplementary things that I think are probably not very important for the majority of the population of veterinarians. All right, so a little bit about vascular access. We all know we can get blood vessels anywhere, right? So ideally, we just need to hit one of the blood vessels and vein, hopefully, and be able to secure it into a patient. So jugular veins, cephalics there for the cat and the prior dog. Ear veins, we've had to do a few on some big dogs at Points East, unfortunately. Hopefully everyone remembers vet school and doing them on pigs. So all of them are options, just venous access. Sometimes it does require a cut down, be able to cut through the skin and raise up the vessel and be able to go directly into the vessel. Again, leave that open. Doesn't make a difference. If they're dead afterwards, you've not done any more harm to them. If they're alive, then you suture it back shut and then you give them antibiotics. Not a big deal to be perfectly clean, but you do want to shave a little bit to at least be pseudo clean. All right, let's talk a little bit about our drugs. Everyone knows the drugs, hopefully for the most part now. We talk about 2 different drugs. Epinephrine is our first one. Probably our most important drug in CPR, honestly. And again, this is part of advanced life support, not basic life support. So we do basic life support first. Epinephrine we're going to be giving for getting vasoconstriction in our periphery and our gut, not for increasing the heart rate. Increasing the heart rate is a bad cause or a bad effect of epinephrine. And can be detrimental to survival, interestingly, but we're giving it to get blood flow back to the heart. We're going to be giving it, I have both weights in kilograms and in pounds. At Points East, we do everything in kilograms, but not everybody does that everywhere. So we're going to give about 0.1 milliliters to 10 kilograms. And so how I remember this is I just take the animal's weight in kilograms and move the decimal place twice. So if they weigh 33 kilograms, I'm going to give them 0.33 milliliters of epinephrine. To me, that's very easy. I can't do the math in pounds. Pounds is so hard on me. But 0.1 mils per 20 pounds is a rough idea. They do make charts I'll show you guys at the end that you can get from Recover for very cheap, both in pounds and in kilograms. So we're going to give this every 3 to 5 minutes, or they say roughly about every 2 cycles of CPR. Remember that we're going to do compressions ideally for 2 minutes. So that'll put us right at about 4 minutes every time that we give it. High dose is no longer recommended. I stated that before, and here's what epinephrine looks like. It can come in different forms. It can also potentially come in, I don't think it comes in different dilutions at this point or different concentrations, which is good. Hopefully nobody has ampules. They're just a mess to deal with, especially during CPR, but they are out there. Atropine. So we're going to be using this in conditions and animals that have high vagal tone. That is it. We're trying to take away the vagal tone on these animals. So think about brachycephalics, abdominal disease dogs, dogs that might have pneumonia and pulmonary disease, even dogs that have had eyeball surgery, and then lastly, dogs that have intracranial disease. So let's say hit by a car. Those are all going to be causes of increased vagal tone in pets, and they might benefit from getting a dose of atropine. Again, here's your kigs in pounds. So we're going to give about 1 mil per 10 kigs. So epinephrine is move the decimal place once or twice. Sorry, atropine is move the decimal place once. So they should almost always line up with each other. This isn't always perfectly the case. If you actually look at the chart for a 10 kilogram dog, I think it says to give 0.95 mils or something like that. Does it really make a difference? No, they're not going to make them more dead, right? So not a big deal. And then give once as early as possible in animals that you think have a disease that might be responsive to atropine. This is what atropine looks like. There are different concentrations out there on the market currently, so just be careful I don't think it really makes that big of a difference, really. So give these doses and you'll be perfectly fine. All right, for any animals that are under anesthesia, we want to go ahead and reverse anything that we can. So that means turning off the anesthetic gas, disconnecting our circuit, and flushing out our system real fast. Hopefully not into our environment, because the last thing we need is a bunch of people doing CPR while they're woozy. And then hooking them back up to the anesthetic circuit. Reverse any alpha 2s that you have on board, so atipamezole or anesthetin for dexmedetomidine. Flumazenil is going to be for the benzo reversals, naloxone for the pure mu opioids. Most all these reversals, the anesthetin, the flumazenil, the naloxone, do not last as long as the drugs that you're reversing, except for fentanyl here. So they may require one reversal to get to ROSC, but it might come back on board afterwards. You may have to reverse it multiple times afterwards, depending on if it has negative side effects after you achieve ROSC. So remember, return of spontaneous circulation for these pets. All right, so I will ask this question and then I'll answer the questions in the chat. What is the preferred secondary, not primary, but secondary drug route to be to occur? And then let's see, while you guys do that. Oh, Dr. Harrington, I'll have you read these questions so that way they stay off of my screen. Can you do that, Dr. Harrington?
Yep. So we have just a few. Would you recommend a venous cut down for emergency patients that present to general practice without prior CPR approval?
So that's a great question. I think the challenge is that if you don't have permission for CPR, the board is always going to lean on the side of doing what you can to save that animal's life. Now, there are people out there that might have religious beliefs that are against doing CPR in their pets, and you might step on their toes. But if you tell them, I was just trying to do the best that I could to have your dog survive, most are going to hopefully understand, and if you apologize. So I would say that you can try a venous cut down, but hopefully you have enough team members such that if you're not having success getting in a peripheral catheter in a traditional fashion, that you'll have someone that can go up and be like, hey, do you guys want us to perform CPR or not? If you don't have that benefit of time, then you're kind of stuck, and I'd probably say go ahead for the cut down. They're not as easy as they sound. Honestly, I've not had great success myself with doing them, but certainly an option to consider. All right, I'll come back to Dr. Harrington in just a second, just because this won't stay up forever, but looks like most people put intraosseous. I like intratracheal in here. I used to do it all the time during my residency, back when red rubbers were bountiful and easy to find. But so good answers for both of those. All right, Dr. Harrington, what other questions do we have?
So this is before starting compressions. Is positioning the patient right lateral or left lateral more beneficial?
Doesn't really make a difference to me, honestly. I have the ability to adjust what side of the table I stand on, and so to me, it doesn't really matter. I will say that it's easiest to have the patient's back facing you, such that if, because of the slope of their chest, inevitably what happens is that as you're falling off the front of their chest, their body's moving backwards. So if they start to slide off to the edge of the table, you can kind of brace your body up against there and be able to prevent them from falling off the table. So I don't think that right lateral versus left lateral makes a big difference, personally. I believe the recommendations state that it's best to do them. I'm going to go out on a limb and probably get this wrong. In left lateral, and the reason for that I could find it being an advantage is if an animal has pericardial effusion, you can access the cardiac notch that's on the right side between the lung lobes, a little bit easier to get access to the pericardium to puncture a hole in that. So that'd be the only reason why I would say one versus another, but otherwise I'd say any lateral is perfectly fine. Just stand at the animal's back such that as they slide backwards, you've got a way to brace them. Any other
Great.
questions, or is that it?
Actually, this one's not a question. It is a shared information. If not mentioned, the Recovery CPR app is very helpful, and it helps with timing. So there is a Recovery CPR app.
Yeah. There is. I'm going to download it. I'm going to update it as we're talking here, and then I can kind of pull it up and show, wow, that updates really fast. I'll come back and show everyone that just because it is a great resource that we can have. Thank you for stating that. That is fantastic. I always forget about it. All right, so drug routes. So our preferred is always going to be intravenous. As stated in the beginning for the updates on this year's guidelines, intraosseous will be secondary in line. Intratracheal will be third, ideally via red rubber down the endotracheal tube. There are endotracheal tubes that have a disperser at the end of them. I've got a picture of one. But the goal of doing it in intratracheal is just because you're having trouble getting IV access. I used to do this all the time during my residency when we'd have an out-of-hospital arrest come in while they're trying to get an IV catheter. I'm grabbing a red rubber. I'm pulling out my drug, double the drug dose, and then pull up to about 5 mils of saline with the drug in there, and then shoot it down with the goal of hopefully spreading it out to the lungs, and lungs should be able to absorb that just fine, even in a cat. Intracardiac is kind of the last one. So I've never done this before, thankfully. Pretty wicked. I admire the people that have done it. I just haven't had the gusto to be able to do it myself whenever we can't get IV access. Peripheral IV here. Here's a link to the intraosseous catheter. This is via VEN for placing one. I believe this is the drill method. The cartridges are quite expensive on it. And then this is an endotracheal tube that has a built-in catheter for dispersing drugs via that route. Most people don't have that. Just try and envision doing the same thing with a red rubber, get it close to the end of the endotracheal tube and then squirt it in. All right, so electrolyte derangement. So we want to make sure that we're correcting things that could have caused the arrest. So everyone's familiar with hyperkalemia and how that can potentially cause an arrest situation. We're going to give calcium gluconate for that. And we're going to give it about 0.5 ml per kg over about 2 to 5 minutes. So a lot faster than what we would typically do for an animal that is having hyperkalemic related issues. Hypocalcemia, we're going to do the same exact thing as above. So we're going to give, and this is 0.5 milliliters per kilogram of the 10% calcium gluconate. Right now, we have the 23% in our hospital. We don't have 10%, so I have to, doses don't have to be perfect. We're just trying to do the best that we can. And then lastly, hypoglycemia. This is not an electrolyte for sure, but we certainly do see hypoglycemia quite a bit. So we're going to give a dextrose bolus of the 50% dextrose. We're going to give a 0.5 milliliter per kilogram over about 2 minutes. Remember to dilute it because it can be a little bit irritating to the vessel itself, and then you can end up losing the catheter because of phlebitis. Now, if you lose the catheter and you haven't had successful CPR, it's probably not a big deal, but you certainly don't want to lose it before you've called it quits on CPR. All right, volume replacement. So who are we going to give IV fluids to? Only give them in patients you believe to be hypovolemic. So if you have an animal that's been sitting in the hospital for the past 2 days, for me, that's very easy to say. But let's say you've been treating them and they've been staying overnight in your hospital and they've been on IV fluids, there's a high chance that they're not hypovolemic. They might actually be hypervolemic or fluid overloaded, even if their body's not showing you that. So only give them in patients that you believe would be hypovolemic. So these are animals that come in off the street, hit by car, an acute vomiting diarrhea dog, or an animal that's bleeding, let's say got caught in the lawnmower. All bad situations where they could likely be hypovolemic. Or hemoabdomen is a great example with a bleeding splenic mass. So give those patients volume. That's important. You always give a quarter shock dose. Remember, shock doses for dogs, they're 90 milliliters per kilogram in an hour. So we're going to give a quarter of that, so about 20 milliliters per kilogram. Again, I'm back to kilograms, I'm sorry. In cats, the shock dose is about 45 to 60 milliliters per kilogram in an hour. So we're going to give a quarter of that in a quarter of the time. Usually ends up being about 10 to 15 milliliters per kilogram in a cat. A cat dose in general, 60 mils over 10 minutes is reasonable. All right, if you use a pressure bag in big dogs, anything above 300 milliliters, use a pressure bag. Anything less than that, ideally get them set up on a fluid pump would be best. That way you don't overdo it on your bolus. Defibrillation, we're going to do this for 2 arrest rhythms. That's going to be for our ventricular fibrillation. That makes sense. And then we're going to use it in pulseless ventricular tachycardia. We will not use it in any other arrhythmias or arrest rhythms that are present. All right. Humans usually die. Often will arrest due to ventricular fibrillation, and that's why we have defibrillators all over the place with fibrillation. Ultimately, it just looks like a bunch of chaos. It looks like artifact. When I finally pulled the trigger to start to recognize this and treat it, it got to be really exciting using defibrillators. The staff got really excited to see it happen because it doesn't happen very often. And everyone had a good time as much as you can for an animal that's dying, let's say. But it's kind of cool to do and pull out the defibrillator and try to do on a patient. Remember that if you're using alcohol and you try to defibrillate a patient, you can set them on fire potentially. So try to rub out any alcohol and then use contact gel to help get good surface. This ECG down below shows a patient going from a sinus rhythm with a VPC to ventricular tachycardia. In order to call this pulseless ventricular tachycardia, we would have to feel for pulses. But let's imagine that it is. This we might be able to shock out of the ventricular tachycardia state. So worth defibrillating if you have it. Alternative to defibrillation is a precordial thump. So don't be like this doctor that jumps on top of someone with big nose and thumps them in the chest. One, make sure your team knows that you're doing it. I'm going to punch this patient in the chest, and I need you guys to be aware of it. This is to treat his ventricular fibrillation. And two, just try to do it in an optimal way. So in humans, they have standards of you hold your arm this far off, you hold your elbow at 90 degrees, and you thump down with this much joules of force. I have no idea what it is in veterinary medicine. We do not know. So ultimately, what you're trying to target is right over top of the ventricle, and you want to be able to hit it with enough force that you know you're tapping that ventricle really hard and then coming off. So it's a pretty hard force that you're going to use, especially in a big dog. You've got to hit them quite hard. In a smaller dog, not so much, in a cat, even less so. But you've got to make sure that you're essentially causing a mechanical reaction to that heart to shock it back out of a fibrillating state. So again, warn your team. I do this all the time. The team gets really giggly afterwards and baffled, but they always ask and they always are quite excited to learn about it. All right, anyone ever performed a precordial thump before? Yes, no, or you have no idea what I'm talking about? All right, let's see. All right, so most of you have not. A couple of you have. And then one person has no idea, which is perfectly fine. So it's pretty easy to do. Once you get over the fear and the anxiety of doing it, similar to defibrillation, it's quite exciting. And I do feel like I've done it in a couple patients. I've had one that is converted from ventricular fibrillation, or maybe two, to an asystole arrest rhythm. So that is technically considered success. So I did what I needed to do with it. So if you can do it, you don't have to, again, you don't have to have a defibrillator. I don't have one. I don't have a desire to have a defibrillator, and I'm perfectly fine doing precordial thumps on patients. All right, this is kind of a fun fact. Commotio cordis is a condition usually associated with young male athletes, where if you get hit in a particular place at the right time, you can go into ventricular fibrillation. It's kind of wicked. So what has to happen is you've got to hit the heart in the ventricle with a hard surface, and this is why it's most commonly young male athletes, because they're doing hockey, lacrosse, baseball, fighting. And if you hit the heart, or you thump the heart, more or less is what you're doing. It's a precordial thump with an instrument there at the right time. So right here in the upstroke of the T wave, you can cause the heart to go into ventricular fibrillation and actually stop. What was actually wicked was I gave this talk to someone, and someone raised their hand and actually said that it happened to them. And I was so baffled. They're sitting here in front of me and alive, and this has happened. This is probably what has happened with many of the athletes recently that are falling over and undergoing arrest situations in sports. So many of the adult athletes that it's been recognized in. I know there was one in football last year. I can't remember his name. But this is probably what happened to him. He got hit in the chest, I think, with a shoulder or an elbow or a helmet. And he probably had this happen. So wild. fascinating, terrible, but from a medical standpoint, just really cool. So again, in the upstroke of your T wave is when you got to get hit in the heart in the right place. So really kind of crazy, but cool fact. All right, open chest CPR. Let's see, I got about 10 minutes. I'm going to rush through some of this. Open chest CPR. We're going to be doing this when we're already in the abdomen or already in the chest. That makes sense. Just go ahead and unzip that diaphragm if you're in the abdomen and go ahead and start compressing that heart. We have a large breed dog because we're so bad at doing chest compressions in large breed dogs. Animals with pleural space disease, so pneumothorax, pleural effusion, we'll certainly do it. If we have an animal with a flailed chest, ideally we should do this. I gotta be honest, guys, I've done open chest CPR on one patient. It's because someone else unzipped it, and I was just second in line. And then failure to accomplish ROSC within about 3 to 5 minutes. Again, I've never done open chest CPR led by myself. Don't feel bad that you're not doing it or you're not offering it. I don't think that it's a good choice because then you got to take them into the OR, clean out their chest, perform a thoracotomy appropriately, and it's just a nightmare. There's a video on, I believe it's at dove.org or at dove.com. This lady had a giant dog that, this is a criticalist, that passed away, and she got permission from the owners to demonstrate open chest CPR. It's quite fascinating to watch, again, at dove.com or org. But you're going in and you're trying to compress the heart, again, trying to compress at the ventricles first, and using the palms of your hand to compress up. Really kind of wild, fascinating. All right, so monitoring, what's useful and what's not. First, updates to the recovery guidelines. Ideally, you're targeting an end-tidal CO2 of 18. I'm ecstatic and blown away if I'm getting close to 18. I'm pretty happy if I got 12. So 18 is phenomenal. Proper endotracheal tube placement can be confirmed if you've got a CO2 greater than 12. I'll say even greater than 3 or 4, honestly. And humans, because we drink carbonated sodas, you can intubate the esophagus and still get CO2 readings from it. But we don't have dogs that are drinking sodas, so it's probably unlikely to be a problem. They do recommend monitoring plasma potassium, especially animals that are at risk of having hyperkalemia, blocked cats, for instance, to determine if you need to give anything for that. And then the more generalized monitoring that we can talk about is monitoring equipment. So what's going to be useful? We've talked about CO2 levels. So that's going to involve our capnograph to be able to evaluate CO2 levels. ECG for evaluating our arrest rhythm that we have going on and determining if we need to defibrillate a patient or if we have a non-shockable arrest rhythm. Useless, Doppler blood pressure. So Doppler blood pressure measuring device is useless. Some people say you can put it on the eyeball to detect pulses. I tried to do it on a small animal once to entertain my advisor, and I thought it was just the biggest waste of time. So not really a very useful technique or a useful instrument. Oscillometric blood pressure, definitely not helpful. Again, these are revolving are important for us for pulsatile flow, which we're only getting about 20 to 25% of normal cardiac output. Pulse oximetry as the same answer for those. We're also getting lots of motion artifact on our pulse ox, so it's not going to be reliable. Capnograph, we already talked about. 18 is our target. Lower value when compressions are inadequate. So many times what we'll see is someone come up to do compressions and they immediately spike a CO2 level up to 15, 16, 18. And I'm just like, yeah, get it. And then by the time that we're done at 2 minutes, we're down at like 10, 9, 8. And I'm just like, yeah, get off, you're done, you're toast. So it's really can be a great assessment of how well we're doing compressions. ECG arrest rhythms. So we have 3 different arrest rhythms that we'll talk about. We'll throw in a fourth. Pulseless electrical activity, or PEA. So it'll look like this ECG here at the top. It'll look like a normal ECG. Everything will be a little bit drawn out, a little bit wider, and often bradycardic. Important that you have to feel for pulses to be able to call PEA. So you can't say, oh, that's PEA without feeling for pulses when you're doing CPR. Asystole, flatline. Everyone knows that one. Pretty easy there to diagnose. Ventricular fibrillation. Here's 2 more examples of ventricular fibrillation. Again, it just looks like chaos and artifact. Then lastly, pulseless ventricular tachycardia that we're going to throw in as a 3.5er for here is what we're going to do for that. All right, so we've gone over our rest rhythms. We talked about ventricular fibrillation. It's the only one that we can shock. Asystole and pulseless electrical activity, we cannot do anything for besides continue CPR in hopes that we get ROSC. One last aspect that I did not speak about is when we're doing chest compressions and you have your arms, don't have your arms. This is going to be, I'm going to stand up. Let me adjust my picture so that way I can make sure that I can see you guys, or you guys can see me. Don't have your arms bent like this and going up and down like this, like a spring. That will not be effective. So what you really want to do is have your arms mostly straight and use your core to be able to cause those compressions. Your core is going to last a lot longer than your arms will. And 98% of us out there, I'm sure there are some strong-armed people that can do great with chest compressions with just their arms, but for decent-sized patients, it's probably not going to be effective. All right, so let's say we get our patient back. For some reason, I went with him here. We get our patient back. Now what do we do? Oh God, now I got to go through everything to try to keep it alive now. First, we'll start off by, go back to this. We'll go by the updates. First of all, they do not have any guidelines for post-cardiac arrest that have come out yet for the new guidelines. They're expected to be published in 2025. But they did have recommendations and some of in the clinical guidelines, which I thought was a little bit odd. They recommend monitoring lactate to make sure that global perfusion is adequate. Monitor creatinine for evaluating for acute kidney injury. Monitoring BG to make sure that they don't become hypotensive or septic. And then patients that are at risk of another arrest event, which is every single post-arrest patient that you get back, should be on continuous ECG and frequent blood pressure monitoring. That makes perfect sense. I cannot argue anymore with that or agree anymore. So again, all patients. All right, so ultimately, the big thing is treat them like they're a patient under anesthesia. Monitor them frequently, provide them with oxygen, monitor their blood pressure, their pulse ox, their ECG, their capnograph, all those things. Try to get a blood pressure with a systolic blood pressure greater than 90 as a target. Heat support. Some people believe in a slow recovery to normal temperature. Some people believe in getting them warmed up rapidly. In human medicine, they talk about permissive hypothermia will allow the brain to be able to slowly recover and decrease its consumption of oxygen, thereby having a better success of neurologic function return. I say, if you're 97 degrees, keep a blanket on them. If they're at like 90 degrees, heat them up as much as you can to get up to at least 97. Elevate their head about 15 degrees. That will help with decreasing, I'll put my head on my pillow. That'll help with decreasing fluid or blood retention within the brain and allow things for drainage a little bit more. So just 15 degrees, no more than that. Oxygen, 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 because unless they're on fire, they're not going to die of oxygen. They will die of oxygen toxicity if they've been on oxygen longer than about 6 hours. You can lead to detriment after that. And then target CO2 values of 30 to 45. If you're going higher than that or lower than those values, that will affect cerebral blood flow. So we want to go for 30 to 45. And then pain medicines. You just got done cranking on this animal's chest. Holy crap, they're going to be so painful. Ideally, get something that's short acting. So this would be fentanyl would be the best option probably here. What's next? Once they're stable, get them to a 24-hour facility for monitoring. Most animals that come back related to anesthesia, I've had a large number of them. They present to me for overnight monitoring, and they do fantastic. If you can get them back from related to anesthesia, they're typically do really great. Not all of them do, though. So, but I would say most do really well. Get them to that 24-hour facility as best as you can. All right, so resources. Here's a link on the left for the Recover guidelines. Again, you guys will get these, get this email. This is for the website itself. This is a direct link to the 2024 guidelines. You can also back navigate in that website for finding everything else. You can also just search for Recover Initiative, and that should pop up on whatever web browser you're using to be able to find it. You can also find them on the JVEC release in July, August. There's a special issue release that they released, or they sent out. Again, 123 pages for the whole entire document. Don't worry about reading all that. Just skim most of it. Most of it talks about, a large portion of it talks about the studies that they evaluated for each to answer each question and what information was there. Just read the summary of it. We'll be fine. There are these algorithm charts. Oh no. The one on the right here is the post-arrest chart. That is from 2016. Again, they do not have an algorithm chart for now. That's why that is still on there. The one on the left is the new one. This is for doing CPR and what you're looking at. You can buy these from the Recover Initiative website. You can also buy the one that says assessing for cardiopulmonary arrest, so the shake and shout one. So you can get that as well. And then these are the CPR dosing charts. We actually recently got them in to our hospital. Unfortunately, we accidentally ordered the one in pounds. It has a front and a back. Both of them are in pounds. The only difference between the front and back is whether or not it's monophasic or biphasic defibrillators. That's the difference. So if you do things in kilograms in the hospital, just make sure you're getting the kilogram one. And if you do things in pounds, get the pounds one. All right. So in summary, coordinated team with clean communication is a big key to success. Have a prepared area where you've got everything that you need it in, or a mobile ability for it. Take a breath. Give them 10 breaths per minute, 120 compressions per minute, and 2-minute cycles. Pretty simple. You guys can all do this. I can guarantee you can all do this. And then lastly, the most important thing, they're already dead. You're not going to make them more dead. They're already dead. So take a deep breath, because you can do this. We can all do this. And you have the resources available to you to be able to do it, as long as you have the equipment and the drugs and the monitoring that you need. Again, basic life support is the big key. Advanced life support with IV catheter and drugs is secondary. All right, here's my email address for those that would like it. This is a picture of my son on the right, 2 daughters on either side on the top, and the princess dresses. And I think that might be, I think that's the last slide here. Yay. All right. Any questions at all? Please feel free. Oh, looks like we got some things popping up here in the chat. For those that do want to leave, thank you guys very much for attending. I really appreciate it. I love giving these options. I would love to do these in person, but I also love doing them on Zoom. Have a great night for those who want to go ahead and roll out, and then I'll answer any questions that do pop up here that Dr. Harrington will give me.
So far, a lot of thank yous. This is great. I really appreciate you taking the time to put all this together for us.
I guess for those that are still on, we will be sending out certificates in the lecture as well for everyone to have access to. So we'll have, that will come with your certificate. Thank you, everyone.